So, Flavia, I've heard you present at different conferences before, and they're always fascinating presentations. But in one of those presentations, I heard you say something which really stuck with me. And I think what you said was something along the lines of we actually can tell more about people by knowing their zip code than by knowing their genetic code. What do you mean by that?
Yeah, so just full disclosure here, I did not create that phrase or that expression. So I have tried to find the origin of like where did that come to be, and I couldn't find the exact source, but it has been going around for at least 10 years. But it is very helpful to explain the concept. I guess in other words, it's kind of the trade-off between nature and nurture. So the zip code is representing the social context, or someone's neighborhood, and the genetic code is representing their biological characteristics and how those two contribute to what we can know about one's health. And there have been different efforts to quantify, how much each of these sides of the coin, the zip code or the genetic code, nature and nurture, how much they contribute to someone's health. And it is a little bit controversial, but we know that for a lot of chronic conditions, including pain, the neighborhood or the social context can tell us a lot. As I think I alluded to earlier, we in the United States, for example, but this is definitely not an exclusively U.S. issue. We know that people that have lower socioeconomic position have a lot more high impact chronic pain. And so that one person's zip code, it's obviously not the zip code itself that is making someone have more or less pain, but are all the things that come with that zip code, and where can people live, and how can they access different neighborhoods and resources to, for example, go to different schools in different places, and all of the things that may be different from one place to the other. And there have been some studies specifically looking at genetic contribution to chronic pain. And I thought there's an example that was very relevant for me. I think it was about the risk of developing musculoskeletal pain after motor vehicle collision. And they were specifically interested in some genetic vulnerabilities that people could have, and that, that I will say also genetics are not my expertise, so I pardon if my language is not so technically correct in this sense, but they basically saw that at any level of stress that was greater than minimal stress, those genetic subvariants did not make a difference in their pain outcome after motor vehicle collision. So the stress kind of overrides the genetic predisposition, meaning that context, the zip code, if you will, was having a much bigger contribution to the pain outcomes.
So I think that quote, this idea of zip codes being important, and also, what you mentioned about the moving towards opportunity study, that if people move, their mental health can change, really highlights the fact that our neighborhoods and our very proximate social environment makes a big impact. Now, when I think of that, when I think of neighborhood differences, even within my own state, there's so many ways to describe a neighborhood. We could be thinking of, like, do they have sidewalks or not? How close are they to a park? How close are they to healthcare resources, traffic, air quality, safety? There's so many characteristics that go into a neighborhood. When we look at all these characteristics, what are some of the characteristics of neighborhoods that put people more at risk for adverse pain outcomes? Or on the other hand, what are some of the neighborhoods of characteristics that are more protective against adverse pain outcomes?
You put it really well there, the variety of things that could have an impact. I think that we are asking the right questions. We don't yet know, in detail which things make the most difference, unfortunately. And it could be that, they're all contributing in different ways and acting together. They are often kind of connected to each other, like when certain changes happen to a neighborhood, there's kind of a cascade effect that can bring positive change or it can bring negative change. And a lot of those things are driven by shifts in kind of political and balances in power and money that happen in a lot of places. That if there's more investment in a neighborhood, then there's going to be potentially more safety. And if there's also more resources there, then the quality of education may be able to go up. So those things are interconnected, and this kind of speaks to another concept that I think is really helpful when we're talking about social determinants of health, that is the idea of intersectionality, which means that we are not defined by a single aspect of our social position at any given time. So all of the aspects of our social identity and positions, they are with us all the time. So for example, I'm not a woman one day and a Latina the next. I'm always in the US, actually, depending on where I am, I'm defined in a different way. And so we always embody all of our aspects of our social position at the same time. And we're influenced by these different things all at once. And I think going back to the idea of the neighborhood, there is value in trying to tease apart, which are the ingredients that would have the biggest yield if we were to change them. That's what a lot of the research is trying to do. But also, I think our research is evolving in a way that it's combining, the effect of different aspects of the social context in ways that incorporate intersectionality. And I think it represents our lived experience in the world a little better than when we're trying to slice things in different ways to find interventions. Maybe that the way of slicing things and wanting to see independent effects is influenced by a more biomedical way of thinking about research, and those are very helpful as well. I'm not like rejecting that paradigm. I think that we just need to improve it.
So I think the way you defined intersectionality was really, really beautiful, because you were talking about how we're all these different things simultaneously at any one point in time. But I want to ask about that one point in time piece, because you mentioned earlier that when we look at the social environment, it's not just about any one point in time, but it's also about generations ago and even farther than that in our evolutionary past. And I know some of your work looks at these intergenerational effects and how things that happen maybe at different points in time are currently affecting our social environment. So I'm wondering if you can share a little bit about your work on these transgenerational or intergenerational effects.
Yeah, thank you so much for that question. So there are a couple of things related to the intergenerational effects. The research in the area, for example, has documented that children of parents with chronic pain have a higher risk of developing chronic pain than children of whose parents don't have chronic pain. And most of the research to date has focused on how social learning and kind of behavioral pathways could explain this transmission. But there's at least two other mechanisms that are very interesting that are social mechanisms that could contribute to this intergenerational effect. One of them is through adverse conditions during childhood for the child that could be a result of the parent having chronic pain, and specifically tying back to the example that we've touched on a couple of times about kind of financial adversity and the stress that can come with it. So the adverse childhood experiences, that is a part of the literature that I think has been fairly well developed as well, and could be one of the social links in addition to that behavioral piece. And the other part that could explain that, there's also pretty novel and exciting research that is looking at it, that is looking at epigenetic changes. So how the parent and their stress conditions and their social environment more broadly can modify the way that their genetic code is expressed and transmitted to the next generation. And so that could be another aspect of it. And in my research, I was also looking at kind of the opposite direction. So as pain researchers, most of the times we are looking at how certain exposures can make someone at higher or lower risk of developing chronic pain or the prognosis of chronic pain. But in a recent study that I've been working on, I was also looking at how having chronic pain in earlier life, so specifically in adolescence, could impact their later life socioeconomic position. So, for example, when we see in adults, we see that very strong relationship between socioeconomic position and chronic pain, where lower socioeconomic position is associated with more pain. And we are not seeing necessarily what led to that situation. So it could be some of the two directions that I briefly spoke about. So it's the socioeconomic position leading to higher risk of chronic pain and higher impact of pain, but also having chronic pain acting as a barrier to that socioeconomic position later in life. And tying that back to intergenerational effects, in this study, I defined the outcome as intergenerational social mobility, meaning how far can one go with their education relative to their parents. So can they achieve equal to or greater educational attainment than their parents? And does having chronic pain in adolescence make a difference for that intergenerational social mobility and education? And I was very lucky to have access to this public data set called the AdHealth study, or adolescent to adult health, the National Longitudinal Study of Adolescent to Adult Health, that followed up people over time, starting from a nationally representative sample of adolescents back in the 90s who were in 7th to 8th grade. And we knew whether they had chronic pain or not in that baseline. We also knew their parents' educational attainment. And then they were followed up over time across decades until they were in their 30s and 40s, where their education would have presumably kind of have stabilized. They reached their final educational attainment. And I asked the question of, do adolescents with chronic pain have the same level of educational social mobility? And we're still, refining the analysis a little bit, but at first glance, it looked like there was a difference. So specifically for women, so adolescent girls who have chronic pain had lower educational social mobility than adolescent girls without chronic pain, after adjusting for a variety of things. And that was also true specifically for people of non-Hispanic white race ethnicity in the US with chronic pain that had less educational social mobility than people of non-Hispanic white race ethnicity without chronic pain.
I think that has a lot of implications, because part of what you said is that, from generation to generation, there's also these epigenetic changes, but also when you think back at the whole neighborhood and zip code discussion we were having, a lot of where you're born into depends on what your parents did, right? And the social mobility that your parents obtained. A lot of that is luck, and it determines the neighborhood you're born into. So it seems like that study can be suggesting that there might be intergenerational effects, that what you're doing now to treat your pain might influence some pain outcomes for your children or grandchildren potentially, and that's really, really profound.
Yeah, absolutely. And not only pain, right? I think that's the other kind of rich part of this field of social determinants of health, that we often see how that social context also may explain a lot of the comorbidity patterns that we see with other chronic diseases, that people are healthier or sicker depending on their environment. So I'm also interested in how these intergenerational effects can happen for different types of conditions. So, mental health and chronic pain, so definitely the impact of health on our social position later in life will shape the opportunities and conditions of the next generation. And so we could see chronic pain, this link between chronic pain and poverty, as kind of mutually reinforcing across generations. But that also brings up the potential opportunity to break those links and reverse that pattern. So having better social conditions and preventing pain in the next generation, and also preventing a variety of other adverse health outcomes that would come along as well.
So you mentioned health, and it makes sense to me that your neighborhood would, if you live in neighborhoods with less resources, you'd have less access to care and a lot more potentially stress. But what are some of the biological mechanisms by which social neighborhoods and social environments might get under the skin to influence pain or other health conditions? What are some of those biological mechanisms at play here?
Yeah, I think maybe the hallmark one is definitely stress, but that's pretty broad, like at the very micro level. I think that the stress pathways would potentially make us, or when that stress is repeated over time and it's under very little control of the person, we know that can have an effect on that reactivity of the body and kind of ability to buffer these new and repeated stress stimuli. And I would say I generally like to split those mechanisms through which the social context may influence pain in kind of three broad categories. And I'm borrowing from a model that, is used outside of the pain world. But generally, I like to think of them in social conditions that may increase the exposure to pain. So that would be, for example, environments that make it more likely for people to have accidents or injuries. Those could be all the way from like traffic injuries because there's no appropriate signaling or pedestrian infrastructure. They could also be related to, for example, occupational injuries, that people that are working in jobs with poor working conditions would be more exposed to. That could also be in the form of little access to treatment for that acute pain. For example, not being able to take a day off work because you don't have paid sick leave to treat an injury, and then that helps to kind of facilitate that chronification. So first category is more exposure to acute pain or more exposure to pain. The second big group is more vulnerability to the transition from acute to chronic pain. And those are maybe the group of mechanisms that have been studied the most. So they're more related to like how the social context may shape someone's coping skills and emotional functioning and mental health, and things that we know that are those like biological and psychosocial and psychological vulnerabilities to chronic pain. But the novel piece here is to think about not only the biological and psychological vulnerabilities, but how they may be shaped by that social history from in the in utero environment and childhood across the lifespan. And then the third block of social mechanisms that can affect pain would be sort of how the social context influences the resources to prevent and manage pain. So that would be both material resources, but also social resources, like having support from our family members and coworkers and friends, and how those social networks are able to help us maintain a healthy lifestyle, and also to cope with the stresses of life, and to also help specifically with pain and the access and quality of healthcare. Of course, those are a couple of things that we as healthcare professionals always think about. But those resources to prevent and manage pain, I think we can think about how they're shaped by our social positions more broadly, and things that facilitate those lifestyle changes that we often talk about in practice, but thinking about how those in quote unquote choices are shaped by our social positions and the resources that are available to us.
We've talked a lot about social resources, and we've talked a lot about neighborhoods and different intergenerational effects and these big scale kind of overarching social questions that are at play here. And I want to ask one final question, which circles back to the very first thing you said, which was that you got into this line of research by really being in clinical practice and seeing how some of these things were playing out for your patients. So in light of that, I want to ask one final question, which takes it back down to the clinical level. A lot of our listeners are orofacial pain clinicians or orofacial pain dentists. And I want to ask, what can an orofacial pain practitioner do in their everyday clinical practice in light of all this information that you've shared with us today? What can an orofacial pain practitioner do to develop a more informed clinical practice, or to be more sensitive to these topics when they see them playing out in their patients?
Yeah, so those questions are super, super relevant. I think that we need to know what to do next. And we definitely want to expand or really make our practice, I think, coherent with the words that we preach. And I think the biopsychosocial model of pain has been talked about for a long time. And I think there's still room for us to incorporate a lot more of the social aspects into our practice, and also what we do more broadly in our lives. And I think, first of all, I would say that if you're working with patients with orofacial pain, you may already be doing some of this. And I think that's very key to ask the questions about things that are happening in the person's lives in terms of their relationships, for example, their living conditions, their employment, and how can those things be potential barriers or facilitators also for them to engage in treatment and to address the things that are contributing to their pain. And that those are relatively basic things to do, but if they feel outside of your comfort zone, I would highly encourage you to try and get extra training in these things. And a lot of, I think this is not part of our traditional dental training, but they are absolutely core to the experience of pain and being able to treat the whole person, and thinking also about the person not being in a vacuum, thinking about what's around the person and shaping how they go about their lives. And so that, I think those skills come from interdisciplinary collaboration. I think that Dr. Bogueiro, of course, has a ton of expertise in this area, and as a pain psychologist. In the United States, also, a lot of this work specifically with the social aspect of health comes from people who have training in social work. This may be different in different countries, and who deals with these different social needs. And it would be ideal that if you're obviously asking those questions, that you know what to do about the answers, and making them helpful, and not only kind of bringing up difficult conversations without necessarily being able to address them. So it's like we need to up our game in the way we discuss social things. And also that would be kind of step one. So maybe bringing in people in your team to collaborate, to learn more about this. And I think the second part of it is to understand that social inequities in pain are not going to be fixed in the clinic. And I think that's a really big step that needs to happen for us to address the bigger picture issues that are kind of the root causes of these problems. And in many ways, I think historically, we've seen those big picture problems, social problems, as outside of our scope. But as orofacial pain practitioners and advocates, you don't need to be a provider to engage in this effort. But as we learn more about how the social environment impacts pain and impacts health more broadly, we need to use our trusted messenger voice, because we often have a lot of credibility with the public and with policymakers. We need to get that message out there that these inequities are happening. They're shaping both the risk and the prognosis of pain in our patients. They're shaping who actually gets to our clinic in the first place, and maybe who is suffering with those problems without getting access to care. And those things are based on much more fundamental justice issues and distribution of resources that we can advocate for, and we can talk to our colleagues, we can talk to our representatives in the political system, and it's going to take kind of a change in culture. And the more we talk about it, the better. I know that a lot of these topics are kind of uncomfortable to talk about, and we may feel kind of helpless. But it takes talking about it to be able to understand how we may be able to change it. It's going to be a collective solution for a collective problem. So let's not stay, within the walls of the clinic, but we will do everything we can in the clinic, but also let's engage and advocate for bigger changes.
Thank you so much for answering all those questions. I think it's been such a wonderful conversation. And I think when we see patients, a lot of times patients come to us because they might have a problem with their jaw. And we naturally tend to look at their jaw, but we forget that this jaw is in a person, in a social environment, in the neighborhood, in the state, in the country. And all those different levels of play might all be influencing the pain that they're experiencing and how they're coping with it. And I think that that's such a powerful reminder. And you've really opened, I think, my horizon on thinking of how all those different systems might be at play here. So that's really, thank you so much for doing that. And I've really enjoyed this conversation. Thank you.
Thank you for facilitating. Yes, it's been a pleasure.